All right, welcome everyone to the first seminar of the semester for the newly established Tulane Center for Sex-Based Biology and Medicine. My name is Sarah Lindsay. I'm joined by the other leadership of the center, including Dr. Mave Jarvis, Dr. Daniel, Dr. Crousel Wood, and am I missing one person? I think that's it. So thank you. Unfortunately, of course, we're not able to meet in person, but we wanted to bring you some really important information and research from some of the major systems. So we sort of have the first three seminars organized into pulmonary, cardiovascular, and renal blocks. And some of the information that's presented today by our speaker is going to be shared with the medical students through case-based learning. So about the first 20 minutes of her talk is going to be more clinical relevance and information for medical students. And then the last part of the talk will be more about her research. So to give you more information on our speaker, it's my privilege to introduce Dr. Dawn DeMeo. Did I pronounce your name correctly?
Yes.
Okay. She got her Bachelor's of Science in Biology from Yale and completed her MD at Cornell. She then followed that with residency and fellowship at Brigham and Women's Hospital. And she also received a Master of Public Health from Harvard. She's currently faculty at Harvard in the Department of Medicine as an associate professor. She's an active member of many societies, including the American Medical Association, the American Thoracic Society, the American Society of Human Genetics, and the Society for Women's Health Research. She does a lot of reviewing for both grants for the NIH as well as for journals like the Lancet, New England Journal of Medicine. She's on the editorial board of the Journal for the COPD Foundation. She's the associate editor for Clinical Epigenetics, as well as the American Journal of Respiratory and Critical Care Medicine. She has lots of teaching and training from the levels of medical students to graduate students to fellows, as well as junior faculty. And she is very well funded by both local resources as well as the NHLBI, including a U01 that looks at the genetic epidemiology of COPD, a P01 that's on the systems biology of airway disease, where she's the leader of a program project. She also has an R21 on the epitranscriptomics of the aging lung, and an R01. For an R01, she's a site principal investigator for nutritional omics of pulmonary function decline. And she has over 230 publications, over 13,000 citations, and an H index of 60. So very impressive career. And it's my privilege to have you to our first seminar of the semester. Thank you.
Thank you so much. It's such a joy and a privilege to be able to visit Tulane, even though it's virtual. I love New Orleans, and I hope one time that we can have this meeting in person. So it's a real important way forward to think about the objectives of training the next generation of medical students, but also to retrain ourselves to think of medicine through a sex and gender lens. So the objectives of this part of the talk are to describe a role for sex and gender in response to key pulmonary exposures with smoking as an exemplar, and to convince you that women are overrepresented amongst non-smoking COPD, as well as at risk for the impact of smoking at lower exposures, to support the observation that sex and gender differences impact the manifestations of COPD and how a patient may present to us, in particular, women having increased dyspnea across the life course, and also to convey that we need to be aware of biases in our interpretation of symptoms, as well as how we see the patients who present to us in clinic. No need to spend too much time convincing this audience that sex differences have been recognized as one of the most understudied aspects of human health and disease research. And many prior studies and trials have not included equal numbers of males and females. And this is true, very importantly true in lung disease. Sex chromosomes have been excluded from genomic analyses and prior research initiatives. And everyone is aware that in 2015, the NIH guidelines suggested the need to consider sex more systematically in research and analysis, but medical education has not actually kept up with that dictum. So really, we need to think how can we understand and account for biological sex differences in the context of lung disease here so we can educate students to think in terms of prevention and therapeutics for each sex with attention to gender? So again, I always like to set the scene of sex versus gender. So we know sex is the biologic construct related to genetics, hormones, other biologic influences. In the context of the lung, it can relate to airway anatomy and morphology. And then there's gender, the more societal construct, which is broadly related to the environment, exposures such as smoking, air pollution, some of the societal and cultural aspects, as well as occupation and diet. What I won't be able to address because of time are issues related to gender identity and the non-binary aspects that come to bear on lung disparities. And this is a very important article to read if you want to learn more. Many of you are likely familiar with Frank's article that addressed sex and gender as modifiers of health and disease. And here, when we presented the part about lung disease, we were really interested not only in these biologic and societal aspects, but to remind people that the behaviors of our patients and also the behaviors of the doctors really come to bear on how we interpret cough, how we interpret shortness of breath, and how we can really impact the care of our patients. So in the context of chronic obstructive pulmonary disease, this is the 2020 COPD definition. COPD is a common preventable and treatable disease, which is characterized by persistent symptoms, airflow limitation, which is broadly related to not only alveolar abnormalities, but also has an exposure component. And this issue of exposure is really important when we think in terms of sex and gender. If we just think about epidemiology, COPD, although in the setting of the COVID pandemic, has dropped to the 6th leading cause of death for a long time. It has fluctuated between the 3rd and 4th leading cause of death, with it being the 4th leading cause of death in men and the 3rd leading cause of death in women. So from a clinical importance, it is a problem that deserves attention and education. We know that generally in the past, COPD has been diagnosed by a simple breathing test called spirometry, with the standard hard and fast definition saying, well, if we have the ratio of one number, the forced expiratory volume, to the second number, the forced vital capacity, less than 0.7, we'll call that COPD. But because with normal aging, this value decreases, this idea of using a fixed ratio has been controversial. And this is especially important with sex differences in aging. Again, we can't cover everything in today's talk, but there's a whole other aspect of how men and women age and how the respiratory system ages that we won't have time to address today. When we think in terms of chronic obstructive pulmonary disease, it's really important to think across the life course. So although the path to COPD, everyone thinks starts in midlife, we actually believe the path to COPD starts before that, because we know that most individuals may have a normal lung function decline across the life course, if we look at age on the x-axis here and lung function on the y-axis. But some people may get to develop COPD because they have accelerated decline, and others may never reach maximally attained lung function as a young person and actually have a normal rate or even an accelerated rate of decline because they never grew their lungs completely. And some of the work I'll discuss later suggests there may be some sex differences behind this lack of reaching maximally attained lung function. But we know breathing tests aren't enough. Spirometry is not enough. If we look at this research from Alvaro Agusti's group, and we look at SGRQ, St. George Respiratory Questionnaire, and we look at this progressive increasing value, meaning more symptoms, and we parse the data by stage of severity of lung function, with 4 being most severe. Although the most severe individuals have more symptoms, we see across even the most mild lung with COPD, a range of symptom severity. And this wide range of symptoms and functional limitation is not going to be captured by spirometry. And we know, if again we look by age and sex, that women manifest more symptoms, more shortness of breath, more periodic worsenings of lung disease called exacerbation, whether they're less than age 65 or greater than age 65. And this is true across all the severities. So there's this interesting interplay between aging, severity, symptoms, and just using spirometry to make a diagnosis of COPD. So we know COPD is an inherently heterogeneous disorder. It's a syndrome characterized by chronic bronchitis, so cough and phlegm, small airways disease, and airflow limitation, but then also emphysema, which is a destruction of the lung that can occur in the absence of overt airflow limitation. And this complex heterogeneity really adds to the complexity of parsing sex and gender differences. So when we look, both of these individuals can have really limited lung function. They could both have an FEV1 of 40%. But no one would argue that the radiographic presentation of these individuals is highly distinct and has very specific manifestations. There was a really important study that set the field forward in 2007 by Fernando Martinez and his group. They looked at CT scans like the ones I just showed you, and they looked at quality of life data like. And what they noted was that women with COPD reported more shortness of breath and had lower health-related quality of life. But they also demonstrated less overall emphysema. So they had less of the phenotype of lung destruction. And then when they took pathologic samples, they noticed females had thicker airway walls and smaller airway lumens. So they had more of this chronic bronchitis. It really raised this idea, is emphysema a phenotype of men? And this has been a myth to dispel for the past decade. But it did fuel a lot of sex-based research in the field, where people were really trying to address, is emphysema the key trait to study with regard to sex differences related to COPD? But when we think in terms of differential susceptibility to lung disease, I really like to think of sex and gender as the driving aspect between the intrinsic and the extrinsic susceptibility factors, with the intrinsic being the genome, growth and development happening along this context, and then environmental exposures capturing the extrinsic elements. If we look at some of the classic studies that have been published with regard to COPD susceptibility, this is from the NHANES study, a large epidemiology study of the general population. 12.5% of current smokers had undiagnosed obstructive disease, but 5.8% of individuals that would be classified as COPD were never smokers. And we know that the development of COPD is not universal among smokers, but also importantly by sex. Women are overrepresented amongst the preponderance of individuals with being never smokers and having COPD. But this concept of sex and gender and exposures is so paramount to when we think about lung disease and sex and gender differences, whether it's cigarette smoking, vaping, wildfires raging in the west of the United States right now, or biomass fuels. Many of these have sex and gender related impact on the lung that we really need to think about more deeply. So smoking is a very complex exposure that has relation to intensity of smoking, duration, cumulative dose, time of smoking onset, and people have a very variable response. We can have people who smoked a tremendous amount and never get lung disease, and someone who smokes very little and develops very advanced lung disease at a young age. And this overlay of sex and gender differences in lung disease or cardiovascular disease or any other disease, most human diseases that are related to tobacco, needs to really be thought of in the context of the sex differences in the tobacco epidemic. We know as of 2019, 14% of US adults were current smokers. We also know these rates have decreased by sex over the years, but the global trends, although they support a decreasing prevalence of tobacco use, when we look worldwide, the bad news is that due to population growth, the absolute number of smokers has increased. And this is both true of men and women. And when we think of tobacco and regulatory policy, I like to think from a historical framework when I frame sex and gender questions. When we entered the World War, when we saw the Great Depression, World War II, most of the smokers in the United States were men. And in the 1964 Surgeon General's report, women were considered not susceptible to the effects of smoking because this landmark paper on the confluence evidence linking smoking and cancer really was focused on men. But this was recanted in 1980 with the subsequent Surgeon General's report, where the smoking effects on women were noted to be likely more prominent in the coming decades. And then 20 years ago, there was a whole Surgeon General's report on the effects of women and smoking and the need to find the biologic differences. And so this historical perspective is really crucial when we think in terms of lung disease. Early in the 20th century, cigarette smoking was deemed immoral, socially contentious, and radical. So there was this gender overlay. Women consumed the minimal amount of tobacco, but the changing social climate and the nefarious ads by cigarette smoking, which really hit the scene in the 60s and 70s, linking cigarette smoking amongst women to finding your voice. Some of the horrific advertisement linking women's independence to this terrible exposure really laid the way for understanding that tobacco may really have sex and gender specific effects. This is an old but really careful review of the literature on tobacco susceptibility. And in this, they summarized data from over 55,000 individuals and concluded beyond age 45 to 50, female current smokers had much faster lung function decline than males. Again, with more rapid lung function decline being one clinical pathway to COPD, driving potential sex and gender differences. And what we observed, this was research done about a decade ago by a very talented postdoc of mine, Inga Cecile Sirheim, where she observed in a population from Norway that for every cigarette smoked, women had more severe lung disease at an earlier age. And women entering into this study demonstrated much lower FEV1 at entry with less pack years of exposure than men. And, this was really quite interesting because women tended to be overrepresented amongst the social smoker. Oh, I don't smoke that much. I just smoke at parties. I just smoke when I go out with friends. But really, there is no safe threshold of smoking, especially for women. And we also know that female smokers, in addition to this more rapid decline in lung function, they have reported, again, more symptoms, more dyspnea, and they had increased risk for acute exacerbations and hospitalizations. And so again, the clinical relevance of what we're studying in terms of sex and gender differences in COPD really recapitulates back to the societal aspects related to cigarette smoke. But then there's also this issue of what we call latent exposures. And as medical students, as clinicians, we don't really think outside the box enough. What are the other exposures my patient has, especially now, again, in the setting of wildfires, in the setting of climate change? So exposures to ambient air pollution, we know associates with decreased lung function, increased prevalence of COPD. But my own bias is that it also contributes to COPD in non-smokers in a sex-specific, gender-informed way. Again, when we think in terms of the overrepresentation of women with COPD amongst lifelong non-smokers, one, we need to think about women and lung disease in this context. And two, we need to think of the environment writ large beyond personal cigarette smoke. So if I think in terms of what slide do folks need to take away in their mind for really carrying forward into their clinical practice, I always point to this one: sex differences and risk factors in addition to cigarette smoke. We need to think about occupational exposures and how these sex and gender biases in the past have broken down. Women are now working more in traditionally male occupations, including textiles, ceramics, glassware, and these have links to COPD. As I just noted, non-occupational exposures, especially in women in the developing world. Asthma, again, I won't have time to talk about asthma as a risk factor for COPD in too much detail, but there is this overlap syndrome called ACOS, asthma COPD overlap syndrome, and it does suggest more predominance in women. So again, even though women may present as classical asthmatics, they may subsequently develop fixed airflow obstruction later in life. Genetic factors I'll talk about during the research portion, but then the role of upper respiratory infections. All of these features have sex and gender related influences we need to think about clinically. If we think in terms of what else we understand and what we need to think about as clinicians, this is work done by Ed Silverman, who's the chief of my division. And in an early phase of research, when he looked at individuals with the most severe early onset disease, with chronic obstructive pulmonary disease before age 53, the majority of individuals in the United States that he was researching with this presentation were women. And we subsequently recapitulated this finding in the COPD gene study, which is a large multi-center study of over 10,000 individuals with spirometry and CAT scans. So when we looked at males in blue and females in red and parsed it by age, as you see across the x-axis, women were overrepresented in terms of the percent with low lung function at an early age. So this was not just a singular finding for this early onset presentation. This recapitulates. There's a whole host of considerations and explanations why women may be overrepresented with this early onset disease: smaller lung size, shorter survival in men with COPD, some hormonal issues, X-linked issues, secular trends related to smoking, vaping, cannabis use, other exposures, and complex interactions with aging. But a lot of my research has focused on this true sex differences related to the genome and the epigenome. Again, just in wrapping up this clinical portion, part of what really has troubled me for years is this perpetuation of this idea of emphysema as a disease of white men. You know, emphysema is a disease of anybody. And we went to look at this idea of who presents with emphysema. So when we looked again in this COPD gene study, we looked at all subjects, and yes, it was true that on average, men had higher percent emphysema as measured on the y-axis here. But when we looked at these early onset groups, when we looked at the most severe emphysema, when we looked at the most advanced lung disease, there was no difference between the amount of emphysema between men and left and women on the right. So really dispelling this idea that emphysema is a disease of men and really highlighting the need to be more circumspect how we think about sex and gender in COPD for this particular subtype. One aspect as clinicians we always need to consider, and it doesn't matter if it's lung disease or heart disease or other disease, is menopause really changes the trajectory of health and disease. And this is an important study showing that lung function declines more rapidly during this transitional peri and postmenopausal time, and that clinicians should be very aware of that respiratory health can deteriorate during reproductive aging. I think we're not educated enough to think about this. We're not in pulmonary disease, we're not endocrinologists, and you really need to have this at the front of your mind when you're taking a good medical history. So the case that the medical students will see is of a 45-year-old former smoker presenting with morning cough. For 3 years, the individual has had shortness of breath. A series of lab tests were done and lung function was performed. And you know, when we share this case with individuals, we always ask for the differential. One has to be very aware to note, we don't say what the sex of the person is here. It's a young person and everything looks well except for some symptoms. And a lot of the time what happens, if you say this is an individual with this lung function and it's a male, usually they'll say, oh, of course it's COPD. But if it's a female, people really struggle with the differential diagnosis. This is a young person with morning cough. Morning cough is never normal. Shortness of breath, a lot of women will describe their symptoms as being related to being out of shape or, you know, running after the kids, they're too busy. But we really need to take a step back and think about who our patients are. You know, this is a young person with normal liver function, but really thinking at a COPD with this age, you need to think in terms of what are the genetic drivers. Again, I'll touch on this in the next portion. But the case, I think, will be discussed in more detail, but there are a lot to unpack by sex and gender when you think this is a very typical presentation to the clinic. And we need to just think about the broad differential for each patient that we see. For two really seminal papers in the literature, when a hypothetical patient was given to 192 primary care providers. Again, primary care providers are the front line of lung disease. So really hammering home these messages is important. When the ex-smoker presented, same idea, chronic cough, exertional dyspnea, varied the gender, varied the age, provided spirometry. More often than not, women were given the incorrect diagnosis of asthma and men the correct diagnosis of COPD. And this was repeated in Spain, showing that it's not just a typical American bias. So dispelling how we think of sex and gender globally in the context of lung disease presentations is really crucial. So what got me interested in understanding drivers of sex and gender differences and the clinical relevance was really when I was early in transitioning to faculty, was this paper published by the CDC in the year 2000. The number of women dying from COPD surpassed the number of men. This was for the first time this ominous trend was presented, and it really bespeak to the projected increased morbidity and mortality and disease in women related to COPD. And in 2017, the very important paper published in JAMA suggested that there was an ongoing increase in respiratory mortality from 1980 to 2014, with the highest mortality in Central Appalachia related to COPD. But interestingly, the rates of death decreased in men, but national rates increased more than 100% in women. So this idea of parsing the epidemiology by sex and gender is more important now more than ever. So this is the final clinical takeaway slide. We really need to take a picture of this, keep it in our mind as we see patients in the clinic and the hospital, that COPD is generally underdiagnosed and suboptimally treated, that the disease presentation may be different with women generally being more younger. The socioeconomic status is a really important aspect where there is this inexorable link between poverty and COPD in women. Disease preventive strategies need to be more circumspect between men and women. We need to think of the variety of exposures, including non-occupational exposures. And I'm going to pause here before I launch into the research component. For any questions you can put in the chat or just ask them verbally.
Yeah, I had one question. So you mentioned about the importance of menopause in consideration of the diagnosis. So it's kind of thought that nicotine could actually negate the protective effects of estrogen, but it seems like in this case, you're still having protection of estrogen that's being lost after menopause. Have there been any studies to look at menopausal hormone therapy and its ability to protect?
Yeah, this is a really important question. And I think that the jury is still out. I think it's a big open question in the field. There have been a few studies that came out of the Nurses' Health study, but again, none of those studies included direct spirometric measures of lung function. So as we do some of our research, looking at hormonal effects on lung function and lung function declines, we're trying to address that not only with exogenous hormone, but actually measuring hormone levels across postmenopausal phases to really try to understand that. But I think there's not been really rigorous studies that have addressed that. I don't know if, Frank, I don't know if you have a different take on that as an endocrinologist, but right now I think we need more research.
I have another short question, actually. What is the anatomical, if there is one component of women's more severe and earlier exacerbation of the disease?
So this is a really important issue. We know that women have smaller airways in general and have more predilection towards airway inflammation. And so perhaps one of the earliest manifestations may be due to sex differences in airway anatomy and airway inflammation. Again, it's an area of ongoing research. And for my own work, I'm very interested in differences in this emphysema phenotype. Why is it that, we see different rates of actually parenchymal destruction? So I think, we need to do more to understand the susceptibility to parenchymal destruction. Some of it may be related to differences in xenobiotic enzyme expression, for example, how cigarette smoke is metabolized or how other xenobiotics are metabolized and how that impacts small airway inflammation. But again, ongoing research area.
This is Jay, Frank. I mean, I'm a pediatric pulmonologist, and actually, it's interesting because in preterm infants, there's definitely a male predominance toward worse lung disease for bronchopulmonary dysplasia, for example. So I think it's dynamic over time, and so, but it's really understudied, as Dr. DeMeo alluded to.
Jay, thank you for that comment. Nice to see you. I think this is a really important point, and sex differences in early life and sex differences in lung development are really crucial here. From sex differences in adolescence, we know that asthma is more severe in boys, and then there's this pubertal switch where we see girls develop more severe asthma post-puberty. And exactly as you say, BPD, effects of BPD more severe in baby boys. Maybe this is related to the disproportionate lung growth between airways and lung parenchyma. We know happens in baby boys, dysynaptic lung growth. Again, investigating this by sex is an important area that we're now investigating using genomics.
And a very last question, do you think that the exacerbation after menopause is due to a loss of the anti-inflammatory effect of estrogens in the lungs?
Yeah, I don't know. I mean, I think I'm not sure, because we definitely see more inflammation in women, and whether that's related to, again, how epigenetic effects perpetuate lung inflammation differently by sex. Again, I'll show you a little bit of research in that direction. But it's unclear. And I think the question always, is it hormone, or is it some complicated interaction between the hormonal milieu and what happens at the level of the genome? I don't think we know yet.
Okay, and I think we had one more question by Dr. Walu. Do you want to ask your question?
You wanted me to ask it?
Yeah.
So one of your slides show clearly, the female during the menopause has a higher rate of the COPD, right? COPD disease.
Mm-hmm.
So I'm curious, during that period, is any sex level, like a female hormone level, highly associated with the pulmonary immune system? That's why they suffer worse disease, or in one way or the other.
Yeah, I think this is a really important question, and it's a direction we're taking our genomics research to try to integrate this idea of what happens from an immunomodulatory standpoint as exogenous hormones are introduced, endogenous hormones decline. I think that it's been under-investigated in lung disease. And so from a molecular standpoint, I don't think we really have a good sense yet of the why. We know it occurs, but we don't have a good sense of the why.
I have one more, one more question, not related to this specific disease, but related to lung cancer. It's actually information I got from my friend, a doctor from China who's a lung cancer surgeon.
Mm-hmm.
And he observed that female in China tends to suffer worse and more lung cancer. This is also sex, and a lot of them are non-smoker, and some of them are not actually exposed to secondhand smoking environment. So they have no idea how that happened. But there's two trends. One is the female suffer more lung cancer. This is also associated with this COPD as well, because chronic COPD highly associated with the lung cancer. So, and also the age tends younger, which is coincident with the menopause. So,
yeah, this is a really important comment. I mean, and I'm talking about COPD today, but we do have a new direction where we're trying to understand the sex differences in lung cancer. It is absolutely true globally that women are overrepresented amongst lifelong non-smokers with lung cancer, and it does present at an earlier age. And it really, again, is an understudied area. And we know that emphysema is along that chain of diseases that is associated with higher risk of lung cancer as well. And so I think there's something that we need to combine our study of non-neoplastic and neoplastic lung disease when we think of the influences on sex and gender differences. But this lung cancer and the COPD stories, both of them have been broadly under-investigated and poorly understood in terms of sex differences.
Thank you. Thank you.
So the second part of the talk is really, I was asked to give a little bit of a highlight of the research that I've been going on. So I've been at the Channing Division of Network Medicine for more than 20 years now. We're one of the only research-only divisions at the Department of Medicine at the Brigham and Women's Hospital. My secondary appointment is in pulmonary and critical care. And it's really been an important place to be able to do research. And I think just in terms of how I got to where I am, I started as an undergraduate in New Haven. I was a biology major and I thought I was going to be an orthopedic surgeon. So I did basic science research in orthopedic surgery. And that took me to Cornell because the Hospital for Special Surgery is where everyone goes if they want to do orthopedic surgery. But then I got very interested in lung disease, and that brought me to the Brigham for my house staff training and the Harvard Combined Program for my fellowship. And during my fellowship training, I got very interested in advanced lung disease. I was a lung transplant attending for 15 years. And during my fellowship training, I also got quantitative didactic training at the School of Public Health. And so I've been at the Brigham for 25 years now and really have been blessed with this career that's spanned academic medicine, and with the whole idea that my interest has taken me for this trek towards precision medicine. We think about risk factors for COPD, starting with in utero exposures, proceeding across the game of life, across the life course with a variety of exposures, and into later life. And that as we start this trek through the game of life, the trek looks similar and different, whether you're a man or a woman. And I think this is a really interesting review. It's titled Bridging the Gap, Everything That Could Have Been Avoided If We Applied Gender Medicine, Pharmacogenetics, Personalized Medicine in the Genderomics and Sexomics Era. It's a mouthful, but I think it really does highlight this idea that now in this age of molecular medicine, we have an opportunity to really think in terms of what may be some of the sex differences, but then really tackle this more elusive aspect of gender as a non-binary issue and the influence on OMS as we try to understand lung disease. And so I've been sharing this idea that we want to understand the role for genetics and big data in sex and gender medicine. And I know Arnold spoke to this group in April, and I think he's a big proponent of this. I want to share some of our observations in lung disease and note a role for the epigenome and sex differences in the lung. But as I said, I'm in the division of network medicine. So I'd like to share this idea that there's a role for networks as we try to integrate sex and gender differences in understanding COPD, because I really believe that the path to precision pulmonary medicine is going to be through integrating sex and gender with molecular features in a more holistic fashion. So if we think in terms of genomics, which is what my research has focused on, to mitigate lung disease, we can put any disease in this framework, where we think in terms of primordial prevention, primary prevention, secondary, tertiary, and we think in terms of our populations and our goals to either reduce disease risk, preventive medicine, which we're only coming to now in the United States, versus working our way to reducing complications of disease. I think genomics really allows this vision to get there. And if we think in terms of the lung, this is from an NHLBI workshop, where really the idea is to, if we think across time as the life course, we want to get to the point where we're not only curing disease, but preempting disease. And my own interest and my own research is not only to get to this point, but to get there in a sex and gender aware fashion. So the future of medicine is big data. We're very biased, we say that. But big data doesn't just mean genomics. We're at this really unique time in medicine where we have extensive data, where there's massive volume, whether it's imaging or genomics. There's variety, there's wearables, there's multiplicity of formats, and the velocity that we can accrue data is unprecedented. So the mandate for medicine is to train our students to be quantitative, to be computationally literate, and to really bring these tools to bear to sex and gender. Again, when we think in terms of the lung, I presented this earlier, that individuals can develop COPD either by not reaching maximally attained growth, by early decline, or a combination of these. And we think that this differential susceptibility is really something we need to capture through the sex and gender lens. So when we think of genetic drivers of COPD, everyone first thinks of alpha-1 antitrypsin deficiency. The singular proven genetic risk factor for COPD, or at least it was the first. It's a classic Mendelian syndrome, and the disease is typically caused by the inheritance of 2 copies of a gene, which produces this defective protease inhibitor. So this is a Mendelian recessive, and I think that many of us have learned about it, but we forget to think about it when individuals come and present with early onset COPD. So we had done some alpha-1 research. This was research I did early on as a junior faculty. We looked at age across the x-axis and lung function on the y-axis, and we looked at smokers in the open squares and non-smokers in the filled squares. And what we saw in this Mendelian disease, so this is, we know it's a susceptibility factor for COPD, was that there was a broad variability. If we put COPD here at this line, the majority of individuals with this genetic defect had a history of smoking, but not everybody, suggesting an immense variability for the susceptibility to this genetic disorder that was due to some gene by environment interaction. And we went on to look at sex differences in alpha-1, and this is work done by Woojin Kim, who's a very talented faculty member now currently back in Korea. And what we did was we pursued some variation on these 2 genes, which are on chromosome 15. This is a nicotine receptor gene, and this is an iron transport gene. And when we looked in all subjects, we found an association with genetic variants with lung function, but we also saw an interaction by sex. And this was back in the day, if you tried to write sex in journals, they changed it to gender. So that's why it says interaction with gender. But we saw that when we did the interaction models, which was new back then, and when we also stratified by sex, that these genetic variants in the setting of this Mendelian disease seem to be more relevant in males. So again, not only talking about the Mendelian risk, but how the Mendelian risk may vary by sex. And this is something important to think about in CF, as well as any other Mendelian syndrome. So again, going back to more general COPD, we refer to COPD as a genetically complex disease. Alpha-1 antitrypsin deficiency accounts for only 1 to 2% of COPD, and most COPD likely results from multiple genes and environments. And we're now at this place in molecular medicine where we can test this hypothesis-free on a large scale. We know that there are historical evidence for genetic determinants of COPD. When we look at lung function in general populations and twins, we see clusters of how lung function looks in families. And we also know that several studies have shown higher rates of airflow obstruction in first-degree relatives of people with COPD. So again, suggesting an underlying genetic etiology. So how do you do this work? So you gather a large population. We have these abilities to now use these kinds of chips to genotype the genetic alphabet of large-scale populations. We put it through a computer science processing, and we come up with this idea of what genes are associated with this disease. And we can do this on multiple populations. And as the years have progressed, we've done this on a bigger and bigger scale. And so if we look at COPD genetics, this is work published by Brian Hobbs in our group. If we look across the human genome and on the x-axis, we see chromosome number. Of course, no X and Y chromosome, and I'll talk about that in a minute. We see multiple areas across the genome that rise above this line of significance. So these are all the other genes that we now believe may be associated with COPD. There's a lot of them. And I've been very interested, how do these risks aggregate together. So if you take COPD risk alleles and you put them together and develop this idea of a score, the more genetic variants you have, individuals have been shown to have lower lung function. And this has been repeated in studies by Louise Wayne and her group from the UK Biobank as well. As you accrue more risk genetic variations, you have a higher risk for COPD. But what about sex in this construct? What about gender? So we know that sex-specific genetic architecture has been described for many human traits, including lung function, and that failing to model these sex-specific architecture really limits our ability to make inroads into sex and gender-aware medicine. But ignoring the allosomes has been standard. You have to look really hard at the literature to find systematic looks at the X and Y chromosome in complex diseases, especially of the lung. And so we started thinking about ways to model SNP by sex interactions across the human genome. We did this in COPD. This is work done by Megan Harden, who was a former postdoc of mine, where she stratified our large COPD investigations by sex and found a very interesting signal in women, but not men, in the CELSR1 gene. And this is a very interesting gene. We never get lucky in genetics. And I know some of you who do genetics research know this. And when you find an association that actually has been linked by the basic scientists to something that means relevance to your disease of interest, that's a good day. So Megan identified association in women in the CELSR1 gene, and this gene had been prior described by another group, Laura Yates, as associated with normal lung branching morphogenesis. So this lung development gene, taking us back to that idea is, could it be that women may be more susceptible to certain aspects of COPD because of a developmental susceptibility? So this is work we've been following up. But I always think about this work by Morrow. It was published in 2015 in the Biology of Sex Differences journal. And I think this is really prophetic comment. So can we really understand sex differences by studying the genetic alphabet? We know that the majority of genetic material is shared between the sexes. So how can males and females differ in so many ways if we really don't expect the genetic code to vary? So this got me very interested in the epigenome. So what is the epigenome? So I like to think of the genome, our genetic alphabet, as the musical notes that make us up. And the epigenome are kind of like the composer's marking on top of the genome that tell the genome how to express itself. And so some of these epigenetic effects include changes in the histone, changes in the RNA, but we've been very interested in DNA methylation. And what is DNA methylation? DNA methylation involves the addition of a methyl group. So for the undergraduates, the CH3 group, in the context of a cytosine guanine repeat region. But more broadly, the epigenetic studies capture this idea that the expression of a gene, what the gene is saying, can be changed and maintained by a change that doesn't change the DNA sequence or the alphabet. And so this started to resonate because we know that epigenetic effects play a role in early life as well as across the life course. They're influenced by the environment, they're influenced developmentally, there's stochastic and random drift. In the current age, we know that assisted reproductive technologies impact the epigenome. So DNA methylation as a way to capture the life course of lung disease and sex differences became very interesting to me. We started this work by, again, hearkening back to cigarette smoking. And this is work done by a former postdoc of mine, Emily Wan, who's now faculty at the Boston VA, where she noted if we look at cigarette smoking, and time since smoking cessation, we saw differential DNA methylation across the genome. And if we parse the data by highest versus lowest total pack years of exposure and time since quitting smoking, if we looked at people who quit longest ago and smoked the least, we saw reversion of certain epigenetic marks versus individuals who quit recently and smoked a lot, very distinctly different. And this was a pattern that manifests over and over. So perhaps one of the ways sex and gender plays into epigenetic effects and the environment is changes in the epigenetic plasticity over time that are sex specific. We looked at this in fetal lung and placenta and saw that in utero smoke exposure had certain signatures in the fetal lung, some of which had been associated with lung cancer and some of which were sex specific. Emily then went on with me to look at some sex-specific features of the epigenome in buccal mucosa DNA methylation and identified very interesting sex-specific associations in women, but not in men, and for differential methylation in CYP1B1, which again is a xenobiotic metabolizer. So that maybe the way in which men and women have differences in metabolizing exogenous exposures relates to epigenetic plasticity and variability. Another one of my postdocs, H.K. Koo, a very talented Korean postdoc who's now back in Korea, she looked at sex-specific associations with DNA methylation in lung tissue. And she looked at this across the genome and found multiple areas where it seemed in lung tissue that DNA methylation resulted in a different direction of effect between men and women. So this idea that maybe what's happening in the lung as we try to unpack the sex differences is that the exposures, whether it's smoking, vaping, the environment, biomass fuel, maybe the gene by environment interaction is being driven in a different direction by the epigenetic effects. We've been trying to unpack this by looking at metabolomic profiling. And so this is a study I did with Russ Bowler out at National Jewish. Again, very talented pre-doctoral student, Lucas Gillenwater, did this. When we looked at male COPD subjects and female COPD subjects, we found very different metabolomic signatures with this predominance of metabolomic profiles strongly different by sex, including differences in sphingolipids. And this may harken back to the BPD story, maybe part of why we see differences in babies relates to the sphingolipid and steroid pathway differences. And this is work that needs to be further interrogated by sex. And we also saw sex-specific shifts in other metabolites, acylcarnitines. So again, we're now adding this, doing the same kind of analysis using the proteome. But this really harkens back to this idea of network medicine. You know, we keep unpacking these different layers of the ohms that make us human, the genome, the epigenome, the metabolome, the proteome, pick your ohm. But we really believe we need to bring these layers back together. So I think that the future of understanding sex and gender comes from network medicine. So what is network medicine? Well, we like to say in our division that the key components of network medicine is taking a holistic approach. Instead of being very reductionistic and reducing males and females to a single ohm or a single pathway, we really need to integrate and bring it all together. We really focus on constructing molecular disease networks and trying to capture nonlinear responses of the systems. And these nonlinear responses may be in part why we see such dramatic differences to cigarette smoking. We try to model emergent properties and investigate responses to network perturbations like in utero exposure to smoke. And we use systems biology methods. And so inherent in network medicine approaches are big data, lots of complicated math, and looking at different outcomes. And my hope is to develop a really formalized system to understand the networks driving disease differences in men and women. So again, we've been thinking about this in terms of development. So this is a very important study in lung disease by Peter Lange and group that looked at the different large cohorts, and they followed participants longitudinally. And what they noticed was that low lung function in early adulthood was associated with the risk of developing COPD, this idea of a trajectory. And what I'm very interested in is taking these trajectories and putting genomics to them. And together with this is linking asthma and COPD. And as I said earlier, this is a different study, but we've started to do this in our group. So this is work by Priya Kachru, one of my current postdocs, very talented bioinformatician. And she's been working with me looking at in utero lung tissue exposed and unexposed to cigarette smoke. and trying to understand the early life origins of COPD by building networks from the methylome. And what she's been able to do so far is bring this mass of DNA methylation data together and link what's been observed in fetal lung, building networks in the fetal lung, building networks in the adult lung, bringing these together and trying to say which pathways may be perturbed in utero and recapitulate later in life to lead to COPD. And she's identified several pathways we're following up now. And we've also identified sex differences in these pathways, especially the PIK pathway, this PI3K pathway. And linking these perturbations also link together lung development and aging in the lung. So these are two additional directions we're taking our investigation of sex and gender. So together with Kimby Glass, who's now junior faculty in our group, we've been able to also look at sexually dimorphic targeting using gene expression data. So what does the gene say? So when we look at what a gene says, gene expression, what we see on average is that there is not a big difference in what the genes are saying. What is different is the pathway that the system takes to get the genes to say what they're saying. So it's how the genes are targeted that may be different. And we looked at this in sputum and we looked in blood in these large-scale gene expression. And what we saw that when we looked at female-specific edges in these networks versus male-specific edges in blue, that the genes that were targeted and the ways in which they were targeted were sex-specific. And so this really has led us down this idea that the way to understand sex differences in the lung is through looking at networks. And we did this on a larger scale across 29 human tissues and saw again and again, whether we looked at the heart, the brain, the adrenal glands, the kidneys, that even though on average the genes may not be saying anything different, how we get there is very different. And so in the interest of time, I'll skip through some of this. So what are the clinical relevance of the research I'm doing? I currently have an Ignite Award to bring this kind of molecular work to sex-specific precision therapeutics. It's in its infancy, but we know that there's a lot of interest in the lung of thinking, is the response to inhaled medications sex-specific? Is the response to some of the other therapeutics sex-specific? We know that DNA methylation informs therapeutic response. Again, when Emily Wan was a postdoc with me, we looked at the effect of DNA methylation together with steroids, and we found a very different signature in individuals on and not on systemic steroids. And we believe that some of this therapeutic response we can capture will tell us more about sex and gender specific features of not only therapeutic effects, but off-target effects of medication. And so, again, I'm going to skip through some of this just in the interest of time, but the research that I've shared is some of the ways in which I've been thinking of how to really understand the layers that we need to bring to bear as clinician scientists to sex and gender research. We know that women carry excess burdens of COPD, but we also know that from a therapeutic standpoint, aging in the lung has differences that we also need to capture, and that sex-specific considerations of molecular targets and drug responses really will represent the next wave of innovation in combating lung disease. And so I always think in terms of my research of setting a clinical agenda, we need to suspect COPD, we need to treat nicotine dependence, we need to capture comorbid conditions, but we need to do this with attention to sex, gender, and gender identity and how that all brings to bear on molecular influences. As we think about codifying this in terms of network medicine, I really believe there's a primary role for systems biology and network-based approaches in understanding lung health, but I really believe that the next decade is going to be about big genomic data. And so we're really focused on using multi-omics and systems approaches to use an intense approach to sex and gender differences. And it really is an amazing time to be a physician scientist, to be able to study sex and gender together with all these different molecular omes is really a gift. So this is a little bit of the framework I like to think about, this life course approach, starting at development and getting through all the omes to bring together sex and gender the biologic and the societal constructs together in this omic framework to build this sex and gender aware biomarker-based approach to COPD, with the hope that we can really innovate across all lung diseases to develop a precision pulmonary medicine. So with that, I'd like to end. My funding has been from the National Institutes of Health, the Alpha One Foundation, and like I said, I have this award from the Brigham. Really blessed to have this to think about ways to use OMS to develop precision therapeutics. These are some of the folks I collaborate with, and we're really engaged in mentored training in epidemiology, lung disease, sex and gender, and network medicine. So anyone who's interested in talking more, call me. And I'll stop there and open to questions.
Wow, thank you. That was an awesome seminar. If anyone has a question, you can put your name in the chat and I will call on you. Hopefully you have a few extra minutes that you can stick around to answer some questions.
Yeah.
I'll go ahead and start if no one has a question yet. You touched a little bit on cannabis, so I wanted to know what you knew already about the effects of that versus, tobacco on lung disease.
From a sex and gender standpoint, not much. I think that, again, everyone has their own bias. I think anytime you inhale anything, it's not a good idea. And I just say that plainly. And I think that, my concern is seeing what we know about the sex and gender differences in other inhaled exposures, be it biomass fuel and cigarette smoke and some of the other exposures. I'm highly concerned about the impacts of inhaled vaping and especially inhaled cannabis. But I think, we're only now emerging into those directions. So I can't comment from a point of full literature as of yet. I'll tell you next year.
Okay. The first question is from Dr. Parada.
Oh, I kind of put it in the chat. This was amazing. I think it's so awesome to see a whole journey in research as a physician scientist. I thank you so much for imparting so much knowledge. As an allergist and a pulmonologist, I was wondering, are you looking at allergies and eosinophils? Asthma, NCOPD, and ACO, which is so clinically relevant for people who cannot breathe, are so tied, but there's biologicals, and I know COPD and eosinophils are being studied. Do you have any comments on that?
Yeah, and again, we just don't have the time to cover everything. And we know if we look at the asthma COPD overlap syndrome, which is associated with higher eosinophils, we see women overrepresented with ACOS. We also know when we look at allergic diatheses, even though we see this shift in the early life with boys being more severe, when we see that pubertal swap, whether it's asthma or allergies. So we're just in the midst of some work where we're looking at genetic and epigenetic interactions before puberty. And we are finding some sex-specific effects in early life that seem to be associated with total and specific IgE. Some of that work's under review, so I didn't share it today. But we do see some early life signatures for sex differences. And it's quite interesting because when you look at the epigenetic effects, we don't really start to see a sex difference in the epigenome as of yet until around age 3 in terms of these links with allergy. And that makes total sense. If you think of the atopic march and how that atopic march begins, we really don't start to see it until, a couple of years postnatally. So we are looking at this. I think it's really important. I think it's also important to think about how maternal exposures like maternal vitamin D and, pregnancy-related exposures, how that recapitulates early life to start that atopic march and how that differs by sex. So we are starting to look at that. So that's a great and important point.
Okay, the next question is from Dr. Hongbing Liu.
Great talk. Actually, I have a lot of questions. Maybe I just ask one or two. So first of all, I really want to know the underlying mechanism, the slightly different effect on DNA methylation. How can cause the different methylation? It looked to me it's not change the global DNA methylation, right? So because you can see there's a different pathway change. So how can sexy can cause a amazing effect? That's my first question.
Yeah, and this is a point that we are investigating now with lots of ongoing research to try to answer this question. I think the first is there something about the regulation of methyltransferase pathway genes that we need to look more deeply at to really try to understand, what is that trigger that leads to the cascade of differences in DNA methylation? Is it that there's some hormonal effects? Is it that, it's the pathway that impacts the methyltransferase genes? So I honestly really don't know yet. And of course, we always get back to hormones. What I didn't have time to talk about actually is some of the work we have ongoing on the sex chromosomes as well, because we know we need to think about other influences related to the more of the XY chromosomes related to sex differences and how those impact on DNA methylation. So from a mechanistic standpoint, can't exactly say why it happens. It's just a point that we're really digging deep into now. But what we can say is that we see a difference. And I think this issue of different DNA methylation and the sex differences and how they manifest, I think it's going to be part of the lung cancer story as well. But how it happens is something that we're just in the midst of unpacking now. So I can't answer you fully yet.
Okay, thank you. Another thing is because I'm working on epigenetic, but mainly on histone modification.
Okay.
Do you have any research in your disease related to histone modification?
No, and we've talked a lot about this. I mean, we do in our program, we're doing large cohort research, and traditionally we collect DNA. And so part of it has been, when we think of large scale epidemiology, we just don't have the samples that are appropriately managed to do histone work. But as we get more into disease specific questions, we hope to be able to do more similar, sample preparation that would be appropriate for histones. So some of it is just because this is large scale epidemiology based work. Yeah.
Okay, I have a last one, kind of naive question. So to me, it's easier understand to using sex different, but how can study the gender different? It look to me it's impossible because there's so many different effects, genetic something. So how can study gender specific effects? So
this is the $20 million, or I guess the $1.5 million question, right? So and Sarah and I were just touching on this. So there are some really fantastic papers that are trying to unpack this question. How do we get away from this idea of just sex, the binary sex, and how do we capture gender in the framework of epidemiology? And so some groups have tried to use this matrix approach where you develop a quantitative analog scale so people can put themselves on an analog scale of where they are from a gender perspective. Do we measure occupation and other exposures? So there are actually a few papers I'm reading through now that if you email me, I'd be happy to share as a way to capture gender. And again, maybe the center is addressing this. I think this is a crucial question. For if Tulane uses EPIC, there's now like a whole series of questions in EPIC to address what your gender is. And I think this is really important because we have opportunities to capture not only a binary, how do you identify male, female, but how do you identify along a quantitative scale? And from a biobank perspective, we can bring that to bear together and really inform personalized therapeutics. But again, I don't know if the center is going to talk about gender. I'm working my way through some papers, and if anyone wants to read them with me, I'd be happy to get together and discuss them. Just email me.
Okay,
thank you. Something, you're right, Dawn, that some people are working on that actually to integrate gender into an engine.
Yes.
That would be incorporated in clinical practice, an engine that would ask you, 20 questions.
Right.
Since gender is fluid,
Yes.
Questions will help define whether you where you classify yourself on the gender scale. And then I don't know, it's going to give, you know, a kind of, you're going to be placed on that scale, and that's going to be integrated into your medical record, whatever, but it's going to be like that in the future.
Yeah, I think the ways in which this is really crucial, and I don't know if when Dr. Arnold spoke, he talked about his 4 core mice, right? This is the model, right? The uncoupling of the sex chromosomes from the biology and bringing it all back together. You know, as we see the rise in gender affirming therapeutics and trying to understand the decoupling of X and Y chromosomes with hormonal milieu, I think being very aware as clinicians, you know, from a lung disease perspective, what this might mean, and just as clinicians in general, what happens when you decouple biology and identity and kind of what happens in that framework. I think it's a really important question that we just need to all collaborate together to answer, because singularly we won't be able to answer this alone. So we're trying to do some coding at our epidemiology studies of gender and trying to compare what happens when you model a network by sex versus gender. And how does that change across with aging, right? We don't know.
I think we had one more question on this topic from Allison Van Zant.
Yes, hi, great talk. Thank you so much for speaking. Just a quick thing, this may be kind of off topic, but with the increased, prevalence of assigned female at birth and assigned male at birth kind of transitions, is there anything in the literature that you've seen that has documented like DNA methylation pre and post hormone affirming therapy or anything like that you can touch on?
So right now I know of one small study that has started looking at this, but I do know some of the groups that are very interested in this question are also looking more specifically. We published a couple of years ago a study on Klinefelters and observed some DNA methylation differences. But in terms of what happens to the epigenome, pre and post gender affirming therapy, only now are we starting to see those studies emerge. I think from a single cell, for those of you who are basic scientists, I think from a, understanding at the single cell level, which cells are impacted by these exogenous hormones, I think it's so crucial, but I only know of one. Allison, if you're interested and you want to email me, I can share that small study with you as well as the Klinefelter study.
That would be great. Thank you so much. I will do that.
Yeah.
Well, thank you so much, Dr. DeMeo. We have a lot of comments about your talk being inspiring and awesome. So thank you for being the first one of the semester. And I think people can probably Google your email address if they have additional questions.
Actually, let me put it in the chat.
Okay.
And I have just one thing after everybody's gone to ask you. So if you don't go away.
Yeah, you may not hear from me immediately, but you'll hear from me within a day. So please don't be shy. I'm always happy to talk about research about sex and gender. So don't be shy. Well, thank you so much for this invitation. It's been really fun. And, the pandemic has been awful, but I think if there's one silver lining, I've got to visit places I've never been before. So there you go. Thank you so much.
So yeah, thank you everyone for coming. The next seminar is going to be on September 7th. Dr. Noelle Berry-Mertz is going to talk about cardiovascular sex differences in cardiovascular disease. So thank you.
Thank you, Sarah.
So don't log out, Dawn.
I won't.